I would like to invite Dr. Manju Rahi. She is a senior scientist at ICMR headquarters, and she is the chief of MERA-India. Dr. Rahi, can you hear us?
My apologies for being not present there physically for the lecture. Thank you, Professor Tanner. My deep gratitude to you to agreeing for this talk. I got excited by the talk, by the title of the talk, and knowing that you are coming from president of the Swiss Academy of Arts and Sciences, and you hold a position on the board of Foundation Botnar, research interest, health systems and public health, and you have played a crucial role in the development of malaria vaccine. So, malaria being of deep interest to us from public health point of view, and India is a malaria endemic country. So I think these are very common interests and common area of work between the, our two organizations. I welcome you for this talk, and once again, thank you for agreeing for this nice discussion, hoping for a nice set of questions and which will stimulate our researchers' interest. Over to you, Sachin. Thank you once again.
Thank you, Dr. Rahi. I welcome all of you, all the audience, NMR scientists, other audience who are joining virtually from different parts. And this is a really special talk for us, and we have to reschedule this talk because of some unavoidable reasons. And we welcome Professor Marcel Tanner, and he's kindly agreed, for this talk. I know he is a busy person, but before we start, I would like to give his, official introduction. So, Professor Marcel Tanner is the president of Swiss Academy of Arts and Science and holds a position on the board of Fondation Botnar. He earned a PhD in medical biology from the University of Basel, obtained an MPH from University of London. From 1997 to 2015, he held the position of director at Swiss Tropical and Public Health Institute. At the University of Basel, he served as professor chair of epidemiology, medical parasitology, and public health. He currently holds a title of Professor Emeritus of Epidemiology and Medical Parasitology at the same university. His research interests encompass a wide range of areas, including global health, epidemiology, health system, as well as the fundamental research in cell biology and immunology related to infectious disease, such as malaria. Throughout his illustrious career, Professor Tanner has extensively lived and worked in Africa and Asia. He has played a crucial role in development of malaria vaccine and has been involved in significant programs focused on health planning and training of health workers. He's working closely with the Swiss and Tanzania government. Due to his expertise and contribution, he is a member of various national and international organizations and foundations. He has he's having over 700 publications, 51 book chapters, and numerous reports for the government and international bodies. And on our request, he's agreed to give us a talk on the topic how the corona pandemic develops global public health and strengthens malaria elimination. So, with this short introduction, I request Professor Tanner to start the talk. Professor Tanner, please.
Good morning from here. Good afternoon to India. And thank you very much, Dr. Rai, as well as Sachin, for this very nice introduction. So, I have actually chosen, I now try to share with this word, I try to share the presentation and would like to go into this presentation mode and would like to really come in and first of all have a few words on this title. You may say you are interested in malaria, and now he comes with corona. We have had enough corona over these last 3 years and more, 3.5 years. I have chosen this title because I was involved very much in my position in the task force of our government, but also in task forces of African governments mainly when corona came. And it struck me that many times, and now in a positive outlook, that actually what we had to go through in Corona, we should actually take much more seriously when we are now going forward with our efforts in malaria control and elimination. When we really went through this Corona pandemic, there are so many elements that we should now take up very rigorously for our struggle in doing good research and development, but also public health action in towards malaria elimination. That's where it came about. And of course, talking in and for India, but also for the world, I always take as the content slide the famous story that you know very well about the blind man coming from India long time ago. And it is all these wise people, unfortunately blind. They examined this huge elephant, and a little bit this has happened with Corona. Everybody worked on a bit and reported, and it was all correct. I mean, what you report from the trunk, from the feet, from the ears, and from the body, it's all correct. But it's not a complete picture. It is lacking context. And very often, many of the task forces in the different countries, and I start here with Switzerland, were really focusing on one single issue. And it was always very difficult when you were in a position to really talk to the population, also to the politicians, to put a specific finding into context. And as you now think back of your efforts in the global field, but particularly also with your efforts in India on malaria, very often you are reminded of this story of the blind man examining very carefully and very correctly, but the context sometimes is lacking. Therefore, today in this lecture that you so kindly, Sachin, and the whole MERA invited me is really to go through some challenges. I would like to go back to where we are in malaria control and elimination, and also of what the pandemic brought us. And then we go a little bit about the learnings, not as just learnings and then not doing anything, but really translating it as an outlook for the benefit of global public health. That's what I would like to do. And you know very well that malaria elimination and eradication started for many of us restarted in October, on the 17th of October 2007, when we did the pilgrimage to Seattle. And when they really, Bill and Melinda Gates, certainly Melinda, she was actually using the word eradication and said that everybody has the right to really think about eradication so that we get rid of that. So that's the most equitable way forward. And on the day after this meeting, the Seattle Post brought this picture, and it's the red part here. Even if it proves unfeasible, it should have a big impact. It's like a star. You cannot grab the star, you cannot touch the star, but it helps you to navigate. So what was the situation at that time? And where did we depart from? I mean, I don't have to bring this in here. Eradication was a word that you didn't use anymore after the 60s and the 50s and 60s eradication campaign. Eradication means a permanent reduction of transmission worldwide. Elimination is for a country, for a region, and control is reducing the public health burden. I just wanted to recall this because still up to now, these terms are sometimes used a little bit in a wrong way. Now, but the more important thing, what I want to go back is, where were we in 2007? I mean, important, and if you hear of the regions of the world, we still had 48 countries in Africa with malaria, 20 in the Americas, and Asia were 25. Europe, nothing. and Oceania, we had 2. And we had a total of 95 countries that still had malaria transmission. So thinking about elimination meant, that's for the countries, that you have to stop just controlling burden, but really cut transmission. That's the paradigm shift that is something which really has not only guided us, but actually should still guide us when we think about this aim that not to my lifetime, but to in future, we will really reach eradication. That was the situation. And it is also important that it was not unrealistic to make this claim, because we had around in 2007, deliberately, we had 86 countries that were freed from malaria. So this was the situation where we started. And now you actually think, why does he make the link to Corona? I mean, the point at this time in 2007 also, people applauded and said, yes, we have to go to control and progressive elimination in a country. We felt a little bit like this donkey, and we asked, this is a huge task. How do we do it? Do we just pull this donkey down that it rolls again towards elimination? Or do we really reduce the burden of the tasks that we have? This is just to stimulate you, because the tasks were that we really needed. And that is something which is ever so evident and has been ever so evident also in Corona. It came up that we need to bring together the malaria disease system together with a given health system. So it's not just to study a little bit of malaria and then afterwards say, okay, that's what we do in India, that's what we do in Africa. No, but it is really a combination of bringing, when we want to combine disease and health system, the R&D agenda in a way that when we study here our parasite, it actually has a chance that solutions are brought into a given health system. All these balls here in this theoretical presentation are different in a different country, depending on the social and socio-political setting, as well, of course, the ecology and the malaria system that is in here. So this is the challenge. It's not just a challenge to get this chart rolling again, but it is really bringing this together. And people then started very much, and this is now the map of Africa, because I have this so nicely. This is 2000, the situation with the mapping process. The more red it is, the more transmission you have. The more blue it is, it is less transmission. And in 15 years, or 10 years after the declarations in Seattle, one reached actually a very net reduction, wonderful reduction. And it was actually, and that is something which encouraged us to really think further about the elimination. And we had a 25% decline globally. We had even in Africa a third decline. And of course, it saved a lot of lives. And I think the important thing here was that when we put, instead of a map, we had actually the change that one would actually bring together in an integrated way, vector control, but also the treatment, early diagnosis and treatment. And these were actually the points. We don't have to go now into details of these issues on how we really came from the cases and from the death. We could halve these deaths, we could have this impact which I showed you before. And this meant for a country, and I've chosen here one of my, I would say, as many of you know, nearly home country, because I spent working in Tanzania for the past 44 years, and I also lived there. I think the important point was that from a country in 2000, you have, where it's dark green, there is a lot of transmission. Where it is light green, there is little transmission. But the effect was, only looking at the maps, that you see heterogeneity. That means heterogeneity towards less transmission in certain areas, and certain areas remain high transmission areas. So that's the good effect if you do good integrated control. But as it shows also, it does not lead to an elimination. And it shows you the lessons we learn out of that. And that's something what we also saw with the measures in the pandemic, that then the public health action is to concentrate in a tailored way and not in a blanket way, one size fits all type of approach, but in a tailored way, integration to really do the last miles in these areas where you're advanced, or to go further down, very much tailored in the districts where you are not yet there. So you see the same picture for which is closer to you, very close to you. That's the greater Mekong region, that we all looked at it in a particular interest. And there you also see from the red, from 2012 to 2019 is reduced. That means less transmission. It's more aggregated, and more aggregation means is a classical public health principle that you must be sensitive to heterogeneity. You must not be sensitive, if you are a public health scientist and practitioner, to homogeneity. You must find out where is the aggregation so that you can, in a tailored way, you can intervene. So that's the achievements to the moments that we were saying, yes, we go for elimination and progressive, hopefully later on eradication, that we are actually really bringing the tools we have into the countries. But then we must think carefully what happens when we reach areas where you have this high heterogeneity. It doesn't help you in order to talk about elimination if you just show a big map. This just shows you the dimension of the problem, but it is the heterogeneity within a region that helps at the country level to tailor actions to the remaining setting. As you know very well, these are what we lived through. You have seen the World Malaria Report. And we then actually came to this situation that after 2015, we did see a sort of, these are the cases of stalling, no longer a reduction in a very nice way, or with the death even more. Then you see that something was not going in the elegant way that from 2000 onwards we were achieving with the available tools. And important actually to say is that then during the pandemic, we had actually an annual increase of 13 million cases between 2019 and 2020 during the first year of the COVID pandemic. So what we learn there is really maybe not now directly make the link, but I mean, it's first of all the interaction. I mean, there was a lot written about that. I don't go into details, but if you are so disease focused and less context focused, that many programs that are well underway lose out when a new dramatic epidemic, or in our case now pandemic, comes up. Let's examine these things a little bit further. Why did we actually say that we can go for elimination? And that is something which is compared to the corona situation is different. In malaria, when we spoke the word of elimination and eradication in 2007. Already in 2008, a global malaria action plan was developed, which became in 2015 a document which is known as AIM, Action and Investment to Defeat Malaria. And this is actually the investment case. That is not a strategy. This was the point to generate commitment with a showing that the return on investment is about 1 in 60 or 40, whatever, how you calculate it, but it is huge if you go for malaria elimination. At the same time, and that's now very important, we also had a global technical strategies with 4 pillars: universal health coverage, elimination efforts that you should strengthen that one, and you do surveillance. And thirdly, that's why this red triangle, we have established on the way to elimination this malaria eradication research and development agenda. Not just to do research, but to ask which is the research critical to support the global technical strategy, and against the background of the investment case. When we were struck by the pandemic, as you know from these last 3.5 years, no country had really thought about this triangle, because it was not clear on the global level or even regional level or country level. Is there really an investment case? Is there really? It's just we have a pandemic, we must do something. We didn't have a technical strategy, and we didn't have actually a clear thinking of what is really the crucial science we must do. Not just to say, we need a vaccine. That is of course important, but it was important also already now to think in an epidemic, pandemic situation, what are the longer term consequences of this pandemic, and what are the consequences also besides the disease, but on the social tissue and the economic tissue. So what do we learn here when I talk about this is that we should keep for malaria this triangle. We should keep to work on the investment case, to keep the global technical strategy, but to bring it down, my words before, in the heterogeneity, to tailor the strategy to the local setting, and you keep to have an R&D agenda that actually tells you what is the crucial research, not just research. And I think this is something which we should learn as an outlook. In Corona, I mean, we did a lot of good things, but it was never brought together as in a coherent way for malaria. It existed, and particularly existed from 2015 onwards, when we had all these strategies and investment cases ready. And it is just a note that all those who now say we should actually learn from the example from malaria in NTDs, the neglected tropical diseases, they should also have an investment case. NTDs, they don't have an investment case. NTDs doesn't have a global technical strategy. NTDs doesn't have a research portfolio of the essential research that is being done. So this AIM, that was the investment case. So we concluded, yes, we keep it for the malaria situation. We should have had it for the major pandemics and for the major diseases. But I would like to say something which, in the dialogue to the politicians, are very, very, very important. I go back to history, and that is actually a little bit the past lies ahead of us. In the 18th century, we had smallpox. We didn't have yet the smallpox vaccination of Vienna because this only came in 1796. But before already we knew that in Asia, Middle East Asia, there was a praxis that in smallpox, you would actually do variolation. Variolation means that you take from the blisters of smallpox small amounts that you bring under the skin with a needle of a non-infected subject, and this acts like a vaccination. But it had the risk that if you had too much on your needle from the blister of the smallpox diseased person, that you may actually kill also a so far not infected person. So there was a big discussion in Europe. It was Lady Montagu, the wife of the British consul in Constantinople, who brought this wisdom from Asia to Europe. And the big discussion came, should we do variolation? Is it of the benefit for the population and the society? Interestingly, the king, Louis XV, called for a task force, as many countries called for a task force in Corona, but some hundreds of years later. And one of the task force member at that time was somebody from my hometown, Daniel Bernoulli, whom you know as scientists, the one who did this famous, he's a physicist, the work on hydrodynamica, and showed that airplanes are hanging in the air and are not lying on the air. That's many people know Daniel Bernoulli, but many people don't know that Daniel Bernoulli made a huge public health contribution with a report of the task force that he presented in 1760 to the French king and to the Academies Française, the Academy in France. And he actually wrote in 44 pages all what we actually should have known already, I mean, for many other diseases, but particularly for corona. It was the first approach to life table analysis. All your Kaplan-Meier curves that you use are actually developed by Daniel Bernoulli, and he used it for his first mathematical model. He used smallpox. It's in this work that was published in 1766. He talks about herd immunity. He talks about risk assessment, the individual versus the community risk. He does risk-benefit analysis. He compares the individual ethics of public health with the public health ethics. And actually, in this way, the past lies ahead of us. It's very interesting that all these risk-benefit analyses for measures to be taken were hardly being undertaken for corona, and they are completely lacking also in our document AIM that we use for malaria elimination. So basically, instead of just looking ahead, we should first look back, where we have the elements that guide us on how we really bring interventions and ideas of elimination to the politicians and the society. It is not so much just the investment case, that is important, but it is actually the risk benefit that actually brings people to a public health understanding and context. And I could imagine that if we had done this in this way, a lot of the discussions we had in different countries of the world about corona vaccination with the mRNA or with a vector vaccine would have been totally different. So actually what we keep for our further journey in malaria is really that interventions at the regional and country level should not be only be carried by a return on investment, but should actually, for acceptance in the population, be carried by risk-benefit analysis. Now we come to the vaccine development. Here you say, yeah, we know that, we have followed this, And I think here I don't want an important point where we actually also have learned, and we have learned it actually for malaria even before as for corona, is actually if you want to do a vaccine development of a major public health problem, not only the risk-benefit analysis, what I said before, but it counts, we must see how we can ethically and scientifically correct, we can actually develop, do R&D for such emergency cases, and how can we be quicker. Many people have criticized, mRNA vaccine, this was so quick, therefore it must be a genetic experiment, and we cannot doubt this, and we cannot believe it. And so we had a lot of discussion on acceptance. But you don't overrule the acceptance question by just making it compulsory. The point is that people understand how can you do a short duration. How can you get within a relatively short period, that is what the results from mRNA, the phase 3 trials of 2020 from BioNTech, Pfizer and Moderna, and what is the essence that made it possible? You see, this is the traditional vaccine development where we have sequentially phase 1, phase 2, phase 3, and each phase is a block that actually needs a proposal, a report, must be accepted, and you make the next proposal and so on. And what has actually happened is that you do in the clinical trials here below, you do phase 1 and phase 2 in a rolling procedure, even from phase 2 in phase 3. And with this you gain a lot of time, and you already invest in production, even if you do not have the phase 3 results and not the registration. I think in the conventional approach, you actually do the large-scale production much later when you have all the papers, while here you pack it together, which brings you down to 1 year or even less than 1 year. And that has actually happened. Is that something that we learned from Corona? No. I think this is a personal experience. When in 1992, some of your malaria vaccine specialists, you remember, then was the big question when Emmanuel Elkin Patarroyo had the infamous vaccine SPF 66. And we were together with Pedro Alonso, myself, we were in charge of doing an independent trial. We did it in Africa and Tanzania. And the question then came, but now you do this trial, and every year we have 3 million malaria deaths. Until you have your malaria vaccine, it takes 15 years. And this actually is not ethical. And it is this concept of this rolling procedure that Pedro Alonso with our Tanzanian team and myself, we have actually proposed in a publication in 94 already, that one adopts these rolling procedures. These rolling procedures in this way were then adopted and were used to bring Ebola vaccine much quicker to the populations in Africa, and are now used for the mRNA vaccine. And of course, we would have liked to use it for malaria vaccine, but the SPF 66, as you know very well, was not of public health use, given the infant trials that we did, but it has inspired us a lot on how we can really accelerate scientifically and ethically correct developments of new tools. So that's what we did in malaria. There we didn't succeed. It only succeeded in RTSS. I just would like to remind you that RTSS trials, also the R21 trials, have been based on this rolling procedure, Ebola, as well as SARS-CoV-2. The third element, and that's what I spent a little bit longer, is actually this. Here you see the R&D agenda from control to elimination and to prevention of reintroduction. And this slide is the summary of the summary of the summary of this work that has been done to really see what is needed in research. Not that you just do a little bit of research for the drugs, for MDA, for the single dose treatment, for vector control, for diagnostics, for surveillance, and so on. And I think that was a very useful exercise that was then repeated in 2017 as well, in order to update in the light of the progress made, including also the training part. So the whole thing was there that we said, you know, it's not sufficient that we have some advances in genomics and proteomics and glycosomics and lipidomics or whatever, but actually really we have these tools, and there is still a problem because we saw that is for malaria. We saw this also for now many of the neglected diseases, but we have actually no real pipelines for drugs and vaccines. We had not diagnostic strategies and the surveillance at point of care. We had an adapted R&D framework, which, for instance, through MMV, through DNDi, one could really move, but this needed to really be improved. And the important point is that we didn't bring this together in a R&D movement, I would say, where we would pull on the same strings, because it was also not adapted from all funding bodies that we have to concentrate on minimal essential research and not just research on malaria. But it over time, it improved. And we had then the other questions, of course, besides the research part is actually the community part, which is also research part, a lot of social science and economic research. It is actually not just to look at needs and demands and diseases and illness and perceptions and behavior, but I think what we needed in order to be effective in our action is really that we found out where, I come back, is the heterogeneity of transmission. Who are those people? Where is the potentials and solutions that these people see? And not only the experts who never lived in these villages, and who is really at risk. Not just say everybody is at risk that lives in an area of transmission, but to be even more fine-tuned. Who is resilient and who is actually really here vulnerable. And this means a creative listening to the communities. This cannot be done by people from the north, non-disease endemic areas. This must be done on the spot in order to really tailor the intervention to the people. And the last point is, of course, the system part, not just to look at how do you allocate resources and how do you set priorities, but how the systems function. Where do people go when they have certain diseases, syndromes? Because it's this that helps you to intervene early. So what is the model of health service provision, and how do we really reach people? And I think this question we knew not only for malaria, and we have a little bit forgotten it when we were struck by the pandemic, particularly also in the north and in Europe. It's a huge bazaar of fragmented action, not understanding how a system is used, how people use the system. We could have been much more effective. And by going back to these issues, we actually really strengthen our public health action. What we also learned is actually this picture that you know very well. You need to have the right tools at the right moment. So this man here has, of course, a good tool. He has a saw, but this saw is maybe not the adequate tool to really knock down this tree. Because what do I want to say here? That we are not talking in new tools just if they are adequate and accepted. Of course, that's very important. But also that new tools, and that is something we learn for malaria control and elimination, must be truly transformational. What do I mean? Gene drive in malaria is certainly something which can be transformational. But if you just have the rapid diagnostic tests, that you increase a little bit the sensitivity, then you have a little bit better test, I agree, but this is not transformational. If we really want to achieve the aims, we need the new tools to be transformational and not just a little bit better than what we have. Because with the little bit better of what we have, we do not make a difference in our effort to, for instance, detect early where transmission happens, that's a surveillance issue, or to intervene in an integrated way. So I come back to the global technical strategy, and that the real issue, what we learn, also having been struck now in between of our journey to elimination by the corona pandemic, that the global technical strategy as it stands, and it was approved by all WHO member states, that actually it needs to be adapted and tailored to the local strategy to make the national malaria control programs work. And not the national malaria control programs are using the global technical strategy as a tail at the end, but the global technical strategy serves as the template to be adapted to the different settings. So that is something which we learn, and if you really look at that one, it is a key issues in our current strategy of high burden, high impact, because we did this strategy because we saw that in terms of estimated cases as well as estimated deaths, there were actually very few countries counting for a lot, and very important for the estimated cases. India is among the 11 countries that contribute to 71% of the cases and 70% of the global deaths. So that's why a further tailoring is really in the countries to high burden, because then we have the high impact, and that is the currently strategy which we should maintain with this 10+1, 10 in Africa, 1 in Asia, that is you. And of course this takes into account the challenges that we have of reduced Artemisia sensitivity in the Greater Mekong area, as well as the reduced and sometimes full resistance of vectors to insecticide. This is part of the story. I don't want to elaborate on that one now, but I think the issue is that when we talk about tailoring the strategy to the setting, it means that all the tools we have, from the bed nets, from the early diagnosis, from the drug supply, from the larviciding even, or vector control, to the clinical management, that we really bring this together, and we actually bring the ecosystem and the public health approaches together. The ecosystem and public health approaches, bringing it together, is not only important for malaria, but it is in the whole field where we have to deal with zoonotic diseases. Ebola is a zoonotic disease, corona are zoonotic diseases. This actually goes together, and I think we should take this more seriously and not have on one side the ecosystem people to do the science, and on the other hand the public health science. It goes together, and the vaccine is not as a magic bullet, but is an essential part of integrated control. And therefore also, if you see it like that, even partially efficacious vaccines can do their job if they are used in this integrated way. And that was actually done when we had this committee which called SACME. That was the scientific advisory group to the Director General of WHO, which I had the pleasure to chair, where we actually looked at the scientific elements, if it is possible to reach elimination and then eradication. And we actually developed the issues. Of course, we needed the transformational, here I come back, new tools. We need, of course, universal coverage, but we need mainly surveillance and response to see where we have to intervene with an integrated approach. And of course, if you do this, then you also need the community. And this leads to subnational, even national and regional strategies, and not to one global strategy, this tailoring. And we did actually analyze all this scientifically against the global trends of urbanization, population growth, climate change, etc., etc. And the results were, yes, it is possible, of course, to maintain the elimination and eradication goals, but it also showed, if you look the map again between 2030, that's when you have increases in new tools, and you have actually at this level, then you still have with the current tools in 2017 that we had. In 2013, we have still 200 million cases, and in 2050, we have 200 million cases still. But if the current tools and slightly improved are at 80% use everywhere in malaria impacted settings, then we still have in 2050 11 million cases per year. These were the projections, and that's how the map looked like. Asia is not there because Asia you would have reached the goals, but in Africa we would still have transmission settings. So this was the scientific analysis together with the tailoring to the situation, where it's not a global rule or strategy, but it is the local strategy, which makes it impossible to say that we reach in 2050 eradication. It just shows it's possible to reach major elimination, but we still remain with foci of transmission. The important point is this, again, go back to the strategy and to pick out the important thing that we have to do universal access. Here we are clear, everybody. And here a lot of research goes into understanding systems, understanding populations. That we have to accelerate elimination, I think we all agree, and we know if we do a little bit more today, then actually we have it easier tomorrow. But the key issue is actually that is transform surveillance as a core intervention. And that is actually the red sentence. Surveillance as an intervention is something which should become the central part, because it is where we detect and then act. And act in a targeted, tailored, integrated way. And I think we have very often done too much. And maybe now you get very unhappy with me. You do monitoring and evaluation. Monitoring and evaluation means data collection, the maximum possible. Surveillance, response, or surveillance as an intervention is minimal essential data in space and time, so that you nearly real-time detect when something changes, so that you can intervene. Monitoring and evaluation creates gigabytes of a lot of useless data, that actually you are not overlooking and you are not ready to act in time. So minimal essential data guides surveillance. Minimal essential data, that's a research topic. What are the minimal essential data in space and time? And I think here we actually need to do much more efforts to get this going so that we can bring our strategies of application into the settings as it is here a little bit depicted. So it's not just to have the tools, not just to have a strategy of application, but surveillance must tell us where to act most quickly. And that is the basis then also for effective universal health charge. And it is not something which is, let's say, exotic. It is because, as you know from the antiretroviral treatment, the TB dots, everywhere it's the same issue. Where do I intervene most quickly in this heterogeneity of transmission in order to have the effect we have it? How do we bring it to the people? Malaria is the ITNs, the combination therapy, and in NTDs are the mass treatments and the individual treatments. Everywhere the same issue. And this is particularly important surveillance response in epidemics. And in elimination situation where we must detect the transmission foci, then this is actually a key situation. We must be early, and that's what we learned also with Corona, in order to intervene in a targeted way. Of course, the Swiss shows you a model of Corona with the Swiss cheese. These are the slices of Swiss cheese. Here are the viruses. Here is the individual. Here are the personal responsibilities like wearing a mask or having the distance. And here you have actually the more shared responsibilities by ventilation of rooms, and then later on the vaccines and so on. The idea being that at the end the viruses don't reach our individual here. And why do I show this? Because it was Corona that has shown us most dramatically the difference between efficacy and effectiveness. And that's something which is extremely relevant for malaria elimination and for many other disease control programs. You see, this is a graph that some of you have maybe seen before. I mean, you have a tool that is efficacious, 80%. But you have to gain access. You must know whom you treat or vaccinate. You must have the compliance of the provider. You must have the adherence of the consumer. And it is only this defines effectiveness. So if you have an 80% efficacious tool, but you don't reach 100% here, your effectiveness at community level is 29%. Not 80, 29%. And these are dependent on the health system factors, as well as on how we work together. That blue boxes generate the effectiveness. Now, if you go back to this, to the cheeses and the Corona, the link there, each slice here is actually functioning like as I showed you, each slice. And we had in many countries the situation where people said, okay, when we have masks, when we have disinfectant, when we have distance, this will actually, that is technically maybe 80% efficacious. And then people introduced these measures. And then in the fall 2020, people were surprised that we still had a second wave. And then people said, we did surveys among the people, and people say, we generally do adhere to the measures. But now, make the calculation, if generally I adhere to the measures here, means that from 80%, all these slices are 80% efficacious, and generally means you are 60% adhering, not always, sometimes, but 2/3. So 60% times 80% gives you 48%, let's say 50% of community effectiveness. So that's exactly this example, that you cannot just say we have measures that are efficacious, we must carry them to people, and at the end, it counts also equity effectiveness. That means, who are the people who are effective? If those people who are not effective are the most neglected, the poorest and whatsoever, then you are effective, but you are not equity effective. And that is actually a concept that was, with a lot of pain, we learned it in many countries in Corona, and we have to bring it back to our disease control efforts, our public health actions, and we should also take this very seriously for malaria. You see an example here, Coartem is a very efficacious drug, but you see, my friends, here we had in a district in Tanzania 1,000 uncomplicated fevers, and we asked the question, not the trial, how the health system, how many do they treat successfully? At the end, there were 110 cases successfully treated. So the effectiveness of an efficacious drug over 95% is 11%. If people are not in time, there we lost 400 patients. We had, they didn't reach the providers, and prescriptions were not correctly adhered, etc., etc. So you can not only see how effective it is, but you can also find out, where do I lose my patients? And that's very important when you do an elimination work where you want to cut transmission. You must know where are the weakest points. And not just say it needs community awareness, it needs health education. That's stupid. You must exactly know where. Then you can also, with communication, intervene. And that's something which came from the SARS-CoV-2. Surveillance response, surveillance as an intervention, is reiterated by SARS. If we identify foci and chains of transmission early, we can intervene. So the fire brigade comes when there is little fire. The fire brigade does not come when the whole town is burning. And it is this concept, which is a public health principle, that you must actually detect early in case of malaria where transmission is happening, so you can act. The 137 approach of the Chinese has helped a lot in order of surveillance and response in order to contribute to elimination in China. And this also helps you in general public health terms, that you can avoid when you tailor it to the setting, because in our situation in SARS-CoV-2, it was very clear, an old people's home, a hospital, a sports club, and a bar are different transmission settings. So the measures must be tailored and must be different and must be early, so that we can actually even avoid regional and national measures, and particularly lockdowns that affect the social tissue and, of course, also the economic tissue. And I think that learns us that surveillance response is the way forward for us also in malaria control, but it also needs that we add communication, not information and propaganda, communication. And that's again the same yellow tag comes up. The key is that we tailor in this philosophy the global technical strategy to the national strategy. So I come to the end, you know where you are now, and you look at it as a beautiful picture of your country and the gate of India, and now you see it still, but now it gets completely covered. And you ask the question, why does Marcel now show you this? Yes, we have many new global health alliances, we have many partnerships and so on. So we are in a very good situation that there's a lot of money available. But if we want to be effective in the spirit of the slide I showed you, it needs more than just having all these logos that take the site. But we must actually think of, if we want to move forward, we must have more effective partnerships and collaboration. And that means better defined roles and responsibility. A key in many countries in Corona, and particularly also in Switzerland, is that roles and responsibilities were not clearly described in the process of surveillance and response, in reporting, etc., etc. And I think that is something where global public health suffers a lot, that we have many new initiatives, we have foundations, alliances, consortia, but we should better define roles and responsibilities, because that then also affects the global health governments in a positive way. And at the end, there is something for the scientists, which I have really taken from my very early time when I really specialized in epidemiology. Here is a, science often works like that. You have a huge problem. And the scientist comes and studies and studies and studies and holds this rock and says, yes, I must know more, I should know more, I should even know more. But there is something which Sir Bradford Hill, already in 1965, as you know, Sir Bradford Hill together with Richard Doll were the two who were first showing the link between lung cancer and smoking. And at the very beginning, because they started with a case control study, many people said, this is not clear, the case control study was not done very well, they should do this, they should do that. It's also an ethical dimension. And he then wrote on the causality thing, and he said, all scientific work is incomplete. All scientific work is liable to be upset, and you do more research. But that is now the public health action. And that is particularly important for our elimination discussion. That does not confer to us a freedom to ignore the knowledge that we already have and to postpone action. That means very clearly, we always have, as scientists, already evidence that we can translate for the benefit of community effectiveness to the people. And I think that is what I would like to end also this lecture by saying, it is an ethical responsibility when we use science to drive public health measures, that we always should see what we know and what we don't know at a given moment. This generates the probability, but we should, what we know, already use for the benefit of the people. There is no end day when we know it all. This is a progressive work as the path from control over elimination to eradication it is. So please keep this in mind as a principle, and also remember that for malaria, we must keep the momentum to do it like that. And for SARS-CoV-2, that's why I use this title like that one, we only realize it at the end, and we should have actually realized it at the beginning. So as you have seen, the road to success, there are no shortcuts possible. I thank you very much for this invitation, for listening, and for all the way that we could and can work together. Watch the boat here. Never ever give up. We are on a good track, and I thank you for the collaboration all over the world. Thank you very much.
Thank you very much, Professor Tanner, for this wonderful talk and multiple messages, encouraging messages from you. Thank you very much. So, if you permit, as we said earlier, we'll take some questions with your permission. And first, I would like to request the scientist of NAMR sitting in the conference room if they have any questions. Dr. Nilima and other team members.
Thank you, Professor Marcel. It was really a very good to listen to you. And I just have a small question. Like, as we all know, there are two facets if we talk about corona and malaria elimination. Because malaria as a disease, we have the issue of, like, when we do not have population movement, there is disconnect between the vector and the masses, then certainly we can expect that the disease prevalence will be low. But regarding corona, we expected that corona will decrease the malaria cases in the countries. But unfortunately, this didn't happen. Maybe because the LLINs, the anti-malarias, which were expected to be at the village level, they weren't there. So might have contributed in the increased number of cases, which we saw later on in 2021 and 22. So your insights and your experiences on this?
Yes, thank you very much. Thank you very much for this question. I think my point was here, the comparison was not so much the direct one. I think I had it more on the public health approaches. I did not now discuss this. You went more on the interactions. This would be a lecture as such. But the point is I wanted to show that in any case, it is very important to detect early where a transmission foci comes up, so that you can act. That's why surveillance response and not just monitoring and evaluation, so that you are actually know where something is happening. This prevents that you have to go into larger areas with measures, and Corona was with this particularly impressive because people saw that, oh, we have Corona, and so they made a lockdown of a region or of a town, and maybe had we a good surveillance system, we would have been able to prevent such larger scale lockdowns which affect the social and the economic tissue, which you have seen. India was also a drastic case in that one when we saw the first situation. In India, it was extremely impressive and sad, but also in Switzerland, we could have prevented a lot by not have, because we have a huge heterogeneity in our small country, and we could have lived without countrywide lockdowns if we had had a good surveillance response system. That's what I wanted to show, that the diseases and all the things are different, that the tools are not available in a way, that's very clear. That is to explore further. But it is these principles of public health that we have in malaria elimination. We are much better placed, but we should now not, because of some of the effects we have through Corona, divert from a coherent way of our elimination strategy. That's what I wanted to say here. Yeah.
Thank you very much.
Okay, so we have questions here. So I'll lead. You spoke about eradication versus elimination with the possible zoonotic linkage of malaria parasite, which is null site, Do you think eradication is possible? And should WHO consider this NOLSI a real threat to global elimination plans?
Yes, I think, Sachin, I see it as well in the chat that this comes up. I think NOLSI is something which is a very clear focal situation. It's a zoonotic disease. And it's not a question of eradication, it's a question of elimination. And I think NOLSI is, by having now the awareness, and 20 years ago we didn't enough know the dimension of NOLSI. But now, knowing that we have very specific ecological settings, then we can actually maybe relatively quickly, in this spirit of surveillance response, we can actually reach elimination of foci. This does not mean that later on again another foci comes up, but that's where surveillance response will help. We have the known foci, we act, and but I would not say NOLSI, we just do control. No, you must be coherent. I mean, we know that NOLSI is in the specific area in Indonesia is a problem, but we also know that Vivax is something which is more critical than falciparum. So therefore, I mean, we must be coherent and then tailor the approach. I'm very confident that NOLSI is not a threat to eradication move, but it is a big challenge for the areas concerned to do good surveillance response. Then we will remain coherent. I just see that Manju has here also added that Plasmodium knows a real threat. No, it's a challenge to consider. I would not use the word threat. It's a reality that we have that, and it's actually you should refrain from word threat. It's a complication as resistance development is, but all this can be tackled by a proper surveillance response and not by just say, oh, we have a threat, we cannot maintain our strategy. No, it's the other way around. We have these risks, therefore we must remain coherent with our strategy.
So one more is the efficacy chart needs to be explained. If we want more than 80% output, then what should be investment and access? This is a general question.
Yes, I mean, this chart was a theoretical chart just to show you if you have efficacy of 80%, even combined or as a single intervention. And of course, we would like to have more, but I wanted to be realistic with all what we have. We have hardly anything, and even if you take a drug like Coartem that has 95% efficacy, you only keep a high effectiveness if you have a good access, compliance, and adherence. And I think this is always the same issues. These system factors determine. And many people were in Corona surprised. How we have masks, we have distances, we have hygiene methods. But yes, of course, if people are only adhering and complying to 60%, then even if you have 80%, you have only half, and you have a new wave, etc., etc. And I think I wanted to bring this as a public health principle, and I used a malaria example with Coartem, a drug that we are happy with. I mean, of course, we have the issue of lower sensitivity to artemisinins, but a drug that we are happy with. We cannot, you just exactly explaining, if we have efficacy of 97% of 98, and if compliance and adherence is low, then this 2% increase does not change anything. What must increase is the effectiveness, the way how we bring something to the people. And this is a matter of the health and social system.
So in interest of time, we would conclude this session here. And I am really thankful for Professor Tanner for your precious time. I know you are a busy person, but still you have given this more than 1 hour to us. Thank you very much, and I would like to thank to all the participants from NMR, ICMR, and universities and medical colleges. I can see there are lots of participants here. Thank you very much, Professor Tanner, for your time.
No, thank you very much. I have to thank you all.